Welcome to another episode of Cutting Edge Health. Today, we're talking about ketamine infusion therapy. Is it safe or is it risky? And how can we be able to get insights from Matthew Perry's case? If we haven't met, I'm Dr. Orlando Landrum. I help people understand what are their options for treatment, whether it's physical or emotional, and how can they be able to use those options to get back to leading their life better. So before we get into the science behind this particular topic and discussion today, one of the things that I want to state is there's been a whole host of speculation and media coverage over Matthew Perry's death. To me, I think the proper and prudent thing is to make sure that we look at this as a person and not use sensationalization or being able to make this be something that's not respectful to the person who's passed. But what I do want to do is to also have commentary that looks at the science and has some degree of balance. And one of the reasons why I mention this is, as an anesthesiologist, we have understanding of ketamine and its use, a fair amount, as a matter of fact. And I've heard people who are present within the medical community use this in a way that they state that safety is a major issue. And one of the things that we want to talk about is, like any medication, making sure you have the proper prudent use is important, because we want to not only be able to help people get better, we also want to make sure that we're not doing any harm. So accordingly, we need to know the facts. When we take a look at what happened with Matthew Perry, one of the things that they stated is that he had been receiving ketamine infusions regularly before his death. And one of the things that was listed in one of the various different media outlets is that his last infusion was a week and a half before he died. And for those of you who know, the half-life of ketamine is anywhere from 2 to maybe 3 hours. So traditionally, to get it out of one's system, you may need 3 half-lives or so, but that's basically 6 hours. But the number of days that have taken place don't quite add up. We're going to talk about that. We're going to talk about ketamine's history. We're going to talk about how it works pharmacology from a pharmacologic standpoint, and also what's the specifics of this case. So when we look at ketamine as a medication itself, one of the things that we see is that it has a timeline that's different. It's been used since the 1950s, right? And one of the things that we're able to kind of be able to pick out is that initially it was used as an alternative to PCP for anesthesia. And so what we want to be able to kind of say is, okay, so how did this work if we're talking about using this since the 1950s, right? And so what we're able to understand is that it developed through the use of an anesthetic in a number of different fashions. But basically, in the 1960s and 1970s, it was used on the battlefield. And we're going to talk about that and why that's the case. And eventually, it was listed as a specific type of medication that had to fit a scheduled designation. At the end of the day, ketamine is and has and continues to be used in anesthesia and other different disciplines. And one of the things that we see is that ketamine in particular has been used for general anesthesia, it's been used for veterinary surgery, it's been used for pediatrics, and it's also been used for both depression and pain. I know this because from my own experience, years ago as a resident and a fellow, we use this in various different contexts, particularly for the aspect of pain. One of the times when, as a fellow at Cornell, we had patients that were at hospital for special surgery that we brought into an inpatient unit, and we actually sedated them in a step down ICU unit. And we were able to improve people that had mottled crushed legs from different injuries by using IV therapy to be able to improve their overall pain by using high dose ketamine. And what we saw is that there were changes in heart rate and blood pressure in terms of elevation, which we're going to talk about a little bit later, but the safety profile was pretty darn good. So when we talk about using ketamine in this context, let's kind of go back a bit. So this is a paper from the 1970s that looked at the pharmacokinetics. And one of the things that they state is that ketamine as a whole was a medication that basically had a half-life after being injected lasting about 2.5 hours, as stated before. You can see that that is present longer in the urine and other areas, but basically it's a medication that when you give it for anesthesia, it doesn't necessarily last for a long period of time, and there's reasons for why you want to use that medication. So if we're talking about how that works within the aspect of the system, you give a medication through a syringe. It gets into the bloodstream. That medication then, depending on its concentration, it has various different mechanisms of how some of it reaches it, some of it doesn't. And we've talked about this in another talk where we talked about ketamine, both IV, oral, sub-Q, other things along those lines. But at the end of the day, it gets to the cells and it interacts with receptors. We've had conversations about the numerous different receptors ketamine acts on, but when we look at the pharmacokinetics and how it basically breaks down, we can see that when we give that medication, it only lasts, as you can see in that top left-hand component, for a number of minutes, right? And those number of minutes then result in different presentations that's present in the serum as well as present in the brain. But we're not talking about days of it being present. So let's back up for a minute. Let's say that the ketamine was present in a different dynamic, which we think that maybe that might be the case. What are the main downsides and the safety profiles and issues that can exist with ketamine? Well, when we talk about benefits, one of the main reasons and the reasons why we use it within the aspect of anesthesia is because it keeps the respiratory drive going. So what does that mean in regular English? It's very difficult for you to have depression of your breathing with ketamine. It can be done, but it's not one of the things that traditionally happens. And it's one of the reasons why it's used in some different contexts, as we're going to talk about in a second. But in addition to that, it has minimal cardiovascular depression. So what does that mean? What that means is it's seldom that you have hypotension and bradycardia. So you normally don't have deleterious effects from your heart not being able to pump blood. And one of the reasons why I'm doing this talk is I've heard a number of different physicians talk about this in the last 2 weeks or so. And most of them haven't been anesthesiologists. There have been a few that have been primary care docs. There have been a few that have been ER physicians, and there's been one or two with some really good evals who have been critical care docs, but they haven't used it like anesthesiologists have used it. And we see it in a completely different light. And when you use ketamine, you're normally using it for someone who has potentially shock. And what we see is that those persons who are on kind of the edge, it prevents them from teetering over and not having issues with things like respiratory depression or cardiovascular issues. So what are some of the side effects? For one, it can increase airway secretions. Two, it certainly does, and we see this even in kind of traditional low doses. It can increase elevations in heart rate. It can increase blood pressure and something that's called systemic vascular resistance, right? You can see some hallucinations, and you can see prolonged duration in patients that have liver dysfunction, right? So when we kind of pivot to that, who should this not be used for? Someone who has severe liver dysfunction, someone who has significant coronary disease, and someone who has high blood pressure that's poorly controlled, right? So kind of reiterating, what is the main dynamic of what's present is that it can cause a patient's blood pressure to increase. It can cause an increase in heart rate, but for the most part, it has a favorable side effect profile. And unlike opioids, is traditionally safer and has less problems than what opioids does. So let's talk about this in special instances, as I kind of alluded to before. So when we talk about ketamine used in the battlefield, this was published in Military Medicine 2 years or so ago, where they looked at whether ketamine was an appropriate utilization of a treatment option. And what they found is that it actually was. It was a great medication for being able to prevent patients from having shock issues. And it was certainly safer from an analgesic standpoint than traditional opioids. Another paper looked at it in the context of patients that have asthma issues in the ICU. And what they were able to see is that it actually was able to decrease lower airway resistance and improve lung compliance in patients that were having difficulties with breathing. And so this paper looked at patients who had ketamine utilized that were having spontaneously breathing in the ICU. And what they're able to see is that it increased inspiratory flow, it improved issues that would traditionally be present with patients having difficulty with work of breathing. And all those things were things that were positive, that were good things. Esketamine, which we've talked about in other talks, is a different form of ketamine. It's not using both enantiomers. It's one half. It's Spravato by the traditional trade name. And what they did was they looked at, could it be helpful for, in this particular paper, for patients that had opioid-induced respiratory depression? What they found is, yeah, it counters that. So it doesn't cause respiratory depression. It doesn't have these various different issues that can be present unless you have exceedingly high amounts. So let's talk a little bit about what happened in this particular case. And so one of the summarized view is that Matthew Perry was attributed to have these acute effects of ketamine that resulted in his death, including drowning, coronary artery disease, and the use of buprenorphine, right? And what they found was that he was unresponsive and he had these challenges that took place that were initially attributed to ketamine. The actual report stated that it was drowning, coronary artery disease, and buprenorphine, and those were kind of the other conditions, and the main cause effect was acute effects of ketamine. What they stated was that there were levels present within the blood of 3,540 nanograms per milliliter, and in the central blood, there was 3,271. And what their quote was that traditional anesthetic levels are somewhere between 1,000 and 6,000. Now, my main challenge with this is the following, is how does all that take place? And he had an infusion, which is greater than 7 to 10 days ago. It doesn't add up because IV, even in the context of him having other conditions, won't last that long. When we get into the depth and detail, unfortunately, Matthew Perry, Mr. Perry, had a number of other issues that were present. He had some degree of cardiovascular disease that was present, that was listed in the autopsy report. He had some issues with some degree of liver dysfunction. But at the end of the day, IV infusion isn't going to be the reason why he had the problems that he had, right? And so one of the things that they stated was that the elevated levels that were present likely caused excessive stimulation of the heart and decreased breathing. As we talked about before, maybe, but there had to be really high doses for you to have the changes as present in the breathing. What they talked about was actually the drowning aspect is considered because he lightly submerged in the hot tub and lost consciousness due to the effects of ketamine in the system. Okay, we'll talk a little bit about that in just a second or so. And they mentioned the utilization of this other aspect of buprenorphine, which is, it's an opioid, but it's a partial agonist, which we've talked about in other talks for other things, that maybe had him breathing too slowly with his carbon dioxide buildup. And so that was the dynamic of what they had that was listed in place. So let's talk about medications as a whole and sort of put this in perspective, because I think there's a lot of thought process of ketamine safety. When we look at toxicity and we look at the lethal dose of medications and we look at dependency, this is what we see when we graph these things out. What we see is that probably one of the worst drugs, and we knew this, is heroin. But followed shortly thereafter is morphine. And we use that with some degree of frequency within the OR. We know as an opioid, it's one of the mainstays that we base all our other opioid utilizations in terms of morphine equivalents on how well does this medication work in relationship to how it is to morphine. Other medications that are potentially problematic are alcohol, cocaine, and nicotine that have a high lethality and dependency rate that exceed what's present with ketamine, as you can see down here on the right-hand side lower area. So you really have to have a fairly significant high dose relationship comparatively to other elements and drugs that are present that cause problems and issues. So when we take a look at that, the things that are problematic aren't necessarily ketamine alone, but when we look at this in comparison to heroin and cocaine, it exceeds it by a fair margin if you were to draw out this line in a slope and what it looks like comparatively in terms of other medications that are present. So when we talk about his potential issue, one of the things that we see is the autopsy report talks about, again, the acute effects of ketamine, and we talk about it having some degree of drowning and coronary artery disease. But one of the things that they make mention of is there's other prescription medications that are there. And one of the things that is not really presented so much in the media is that there was some degree of finding ketamine within the areas of the GI tract. And the question comes up, and I'm not trying to lay any aspersions towards someone who's passed and their death is quite tragic, was there oral utilization of the medication or utilization of the ketamine outside of his proper course in terms of treatment for depression that he was receiving from a traditional clinic? And that is a possibility. And it's a possibility that perhaps that, in concert with these other things together, is what resulted in Perry's death. And what we hope to be able to kind of do by giving kind of this evaluation expose from an anesthesiologist and pain physician standpoint is to have patients understand that all of this is in context. When it's done with the appropriate utilization and the safety and supervision of a physician or a provider that is skilled in understanding how to use ketamine and be able to make sure the patient's safe. As a medication, it has a high safety profile that is way safer than comparison to other medications that are present. And when you look at how it's used historically in pediatric patients and on the battlefield, one of the main things that it does is not cause respiratory depression, and it doesn't cause hypotension. It doesn't cause bradycardia, those things that you would think would result in potential death. But more so, it augments those things. For those patients that have lost blood, that are going through shock, it's one of the main utilizations from anesthetic of why we would use that medication as opposed to something like people have heard about before, like propofol. So at the end of the day, this is not meant to be an element that is disparaging towards Matthew Perry, not by any means. And we're sorry for those people who have cared for him and know him as a friend and family for the loss. But we also want to have patients understand who are using this for depression or pain or anxiety or other potential treatment options, the safety profile that exists and how there is a safe utilization of this medication when it's done appropriate and properly for those people that need it. Hopefully this is helpful to some people. If you found this of help, please subscribe to the channel so you can learn more about treatments that may be able to help improve your life, punch pain in the face, whether it's physical or mental, and get back to leading the life that you deserve. Thank you so much and have a great day.